Hello, good morning to everybody. Good morning. This is a holiday and yet, I see here about over 200 participants. And I'm really thankful that you have been joining us. You have been following us for the most part since May 2020. And it was since May 2020 that PCPD decided to hold its webinars because we noticed that many important topics, for example, nutrition, the DOH budget, um, disabilities among kids, they're not being talked about. So sabi namin, pag-usapan natin dito. PCPD can offer the platform and then let's talk about it. At least naman para merong konting, hindi lang raising awareness, pero may konting action. So we did this. And we found out that there was demand. There was a lot of it. And then not only demand, but there were some things already going on. For example, itong learning disabilities. Somebody now is starting to look into the possibility, of starting a learning disabilities among kids, the registry. Yung mga ganun tipo. So ngayon naman, for this webinar, it's so crucial, deaths and births and the pandemic. Ano ba yung connection nito? So makinig kayo because to this morning, I'm really letting you know, we have a whole range of fantastic, outstanding speakers. We have here Professor Grace Cruz, we have Undersecretary G.P. Perez of the Commission on Population, and we have Professor Francis Gialogo, and we have Professor Michael Del Mundo, and our moderator is the eminent, Elma Laguna of the UP Population Institute. So, by the way, this webinar is being live streamed on the Facebook pages of PCPD, of the UP Center for Women and Gender Studies, of the UP Center for Women's Studies Foundation Incorporated, of Angat Bayi, of Women's and Gender Studies Association of the Philippines. So I hope that if you cannot join the webinar, you can look at the Facebook live streaming. Okay, Elma, could you please introduce yourself and the speakers?
Okay, magandang umaga and welcome to this webinar on birth, deaths, and the pandemic. So I am Elma Laguna. I'm Assistant Professor of Demography at the UP Population Institute. And I am pleased to introduce to you our distinguished panelists for this webinar. I'll start with Dr. Grace Cruz. She is currently the Director of the UP Population Institute, and she has a PhD in sociology from the University of the Philippines. Her research interests are in the field of aging, non-sexual risk behavior of adolescents, and population projections. Dr. Cruz is also a member of the Board of Trustees of the Philippine Center for Population and Development since 2016. And she is also currently the Vice Chair of the Demographic Research and Development Foundation. Assistant Professor Michael Dominic Del Mundo is a faculty member also of the UP Population Institute. He serves as consultant to various government agencies and international development partners. He is a graduate of the European Doctoral School of Demography from the Max Planck Institute of Demographic Research and the Sapienza Università di Roma. His research interests include population and development, the demographic dividend, and the health state of the population. Dr. Francis Gialogo is a professor and former chair of the Department of History at the Ateneo de Manila University. He obtained his bachelor's degree in history cum laude, his master's degree in history, and his doctoral degree in Philippine studies, all from the University of the Philippines. He is currently vice president of IBON International, chair of the ACT Teachers Party List, Grand Lecturer of the Independent Grand Lodge of Free and Accepted Masons of the Philippine Islands, and lead convener of Tanggol Kasaysayan, an organization of historians, researchers, and professors of history campaigning against negative historical revisionism. He was author, editor, and co-editor of more than 70 published books, articles, and monographs. He also has a column Baliksaysay for the alternative media outfit Bulatlat. And I will add also that he's one of the few, actually, o baka ikaw nga lang, sir, no? scholars, the specialty is in demographic history, historical demography, sorry. Finally, we have USEC Juan Antonio Perez. Dr. Perez, Yusek Perez is a medical doctor and a public servant of over 37 years of experience in public and private health sector programs in the Philippines. He has headed the Commission on Population and Development as Executive Director since September 2013. He has managed substantial programs for the Department of Health, the USAID, the World Bank, and the Asian Development Bank. He is a key person in the implementation of the Responsible Parenthood and Reproductive Health Law and heads the Secretariat of its National Implementation Team, concurrently serving as its Vice Chair. So yun po ang ating panelists for today. And before we start, there's some house rules. No? We have allotted 15 minutes for the presentation. So each speakers will speak for 15 minutes. And we strongly urge speakers to follow it so to give time for the Q&A from the attendees. When the speaker hears a chime while doing his or her presentation, this means that he or she will only have 5 more minutes. The second chime that she will be hearing means that he or she has another 5 minutes to wrap up the presentation. For the Q&A, attendees may type in their questions in the Q&A box or in the chat box. We will be reading them. The speaker may type in his or his answer also or wait for the moderator to call him or her to answer. We are also streamed via Facebook, so questions and comments through Facebook will be monitored and we will also be entertaining them. Okay. The order of the presentation will start with Dr. Cruz and followed by Professor Del Mundo and then Dr. Dialogo, and Yusek Perez will be the final speaker for this webinar. Dr. Cruz.
Thank you very much, Dr. Elma, for that very kind introduction. So good morning, everyone. And the title of my presentation is, Will COVID-19 Usher in a New Demographic Window of Opportunity? And my objective is to describe the demographic trends in the Philippines, highlighting the significant shifts in births and deaths during the COVID-19 pandemic, and discuss their possible implications. For my data, I got from the various censuses of the Philippines, census of population, and vital registration data, particularly on births and deaths. So let me start by helping understand how population change over time. So population dynamics, or the increase or decrease of a population, is determined by 3 factors: fertility, mortality, and migration. Demographers refer to the balance between fertility and mortality as natural increase, and the balance between immigration and emigration as net migration. Net migration here refers to those who cross the national borders. So therefore, it doesn't include the OFWs or overseas Filipino workers because they are considered temporary migrants and therefore are not expected to establish permanent residence abroad. Okay, so between the two, natural increase is considered the major driver in our country's population growth, largely because of the very high fertility and the low mortality levels in the country. So if you look here, prior to the pandemic in 2019, the natural increase is something like 1 million, a little over 1 million. And this is because we had a total live births of about 1.67 million and deaths is about 620,000. So now, compared to natural increase, the contribution of net migration is rather nil. So if I look at the UN net migration rate estimate for the Philippines in 2019, it was negative 0.626 per 1,000 population, negative, implying that we were losing more Filipinos who decided to live abroad than those foreigners who want to establish permanent residence in the Philippines. So assuming 109 million population in 2019, this rate translates to about 68,000 total net loss due to immigration in 2019. So as you see, this is rather small compared to the effect of natural increase, and therefore usually in our accounting of population change, we don't really look at the effect of net migration, but focus on natural increase. So for my presentation this morning, I'll focus on natural increase, which means births and deaths, and I will not look at the effect of net migration for the meantime. Also because we don't have data yet on this net migration during the pandemic period. Okay, so if you look at demographic trends, they're generally smooth. Barring catastrophic events, population rates are typically stable over time. And this is clearly demonstrated by the smooth fertility and mortality trend over time. So if you look here, last 2 decades from 2000 to 2019, the total number of live births hovered between 1.7 to 1.8 million, no? And no significant or drastic change. And the same with the mortality or deaths, which slowly and smoothly increasing. It's increasing because, of course, the population base is increasing, and as the age structure of the country is also maturing, and we know that those in the older ages have a higher risk of dying, then the net effect would be more deaths. Okay, so the extraordinary conditions brought about by COVID-19 pandemic induced significant demographic fluctuations marked by a drop in the births and increase in deaths, as shown here. So we see here that the natural increase declined from over 1 million in 2019 to only over 300,000 in 2021. At this level of natural increase, the population is still growing, but at a very much lower rate. No? We computed the growth rate for 2021 using this natural increase, and it's something like 0.51%. And it's the lowest annual growth rate registered in the country in the last century. The demographic fluctuations brought about by COVID-19 is not without precedent. We recall the baby boom after World War II, marked by a surge in fertility resulting in a bump in population size. And I illustrate it here with the population structure of Japan, which clearly shows the effect of the reduction in birth rate during the war period and then the baby boom. Okay, so we all know that the baby boom cohort are those who were born after the war until 1964 and are now in their older ages. I mean, those 60 years and over. And to a certain extent, the entry of this cohort, the large cohort, baby boom cohort, into the aging years has explained the rapid aging or the graying of the population in many societies. So what are the implications of this COVID-19 demographic shifts? What is the effect of the decline in natural increase in the short and long term? So let's try to discuss them one by one. For one, we can anticipate a change in the population age structure. Here, I present two population pyramids based on the 2015 population projections of 2020 and 2021. So we see here that in 2021, we only changed the lowest age group, the less than 1, the infants, or those born in 2021, to reflect the number of births in that particular year. And so we see here that there's a sudden drop. Okay. Of course, this is still net of a gross of infant mortality rate. We all know that some of those births in 2021 will eventually die before celebrating their first birthday. So we can still expect that this will decrease even further. So, but these are just estimates, and I just want to show them here to illustrate how the age structure will change as a result of the drop in births during the pandemic period. Now let's focus on the base of the 2021 population pyramid to illustrate the decline in births. Here we show the effect of a single year decline in the number of births. So how will this population structure change in the future will also depend on the future trend in births and death rates. Okay, so if the trend will continue, you can imagine that this pyramid will go up and the succeeding ages will remain the same. It's like the trunk of a Christmas tree if the trend continues. But if it will bounce back, then this will be just a temporary hole in the pyramid, and then it will resume its normal shape. Okay, so Okay, so regardless of the course of the demographic events, we all know that there already exists a demographic break. There's that mark with significant implications. 5 years from 2021, there will be a significantly smaller cohort of 5-year-olds who will be enrolling in kindergarten. It also means a significantly less number of infants and children who will avail of healthcare needs in the next 5 years. This lower population cohort will translate to a higher per capita education and health budget, which with good governance is expected to translate into better health and better education for this COVID generation. The smaller COVID-19 cohort, particularly if sustained, will also mean a reduction in the young age dependency ratio in the next 15 years. When you talk of a young population ratio, we refer to the population less than 15 all over the population in the productive ages 15 to 65. That's one of the indicators we use to see the carrying capacity of those in the productive sector, although it's a gross measure. And of course, if there will be lesser number of those less than 15, then the overall ratio will decline. Okay, so this change in the age structure will initiate the attainment of the long-awaited demographic window of opportunity. But we all know that for us to reap the effect of this demographic dividend, it will require a maximum employment of the working age group to ensure their productivity to support themselves and the dependent ages. 20 years forward, the smaller number of COVID-19 cohort will also be entering the labor market. With a cohort size far less than their predecessor cohorts, we expect an improved employment structure or a picture. Assuming that they have the proper education, skills, training needed for employment, we would see a better employment picture. And more years down the line, we will also eventually see the effect on the support system for our older or aging population because of the lower ratio of those in the labor force and those in the older ages. So these are just a few of the possible future scenarios that illustrate the impact of these COVID-induced demographic shifts. Now, one of the questions being raised recently is that whether there will be depopulation in the Philippines. Is this something that will happen? No? Well, let's define the population. The population is defined as a decrease in the population living in an area represented by a total negative population change due to such natural laws such as more deaths than births, or for some instances, it's also due to negative net migration when there are more people leaving the area rather than those who want to come in, or a combination of these two. Now, if here I project this imaginary line in the future, if the trend will continue, the fertility, the crude birth rate will continue to decline and crude death rate will, increase, then this will happen. But of course, if the trend in fertility and mortality will bounce back to its original pre-pandemic levels, then this is not foreseen in the near future. Okay, so in conclusion, it is clear that COVID-19 has brought about significant demographic shifts, which have short and long-term implications. Yesterday's thinking was that our country's demographic transition will follow a slow, declining fertility and mortality trend, and we were anticipating a projected population that will continue to increase with no definite time frame when the population will stabilize into the future. But the COVID storm came and left in its aftermath a baby bust and spike mortality, resulting in an all-time low level of population growth rate in the Philippines. Policymakers and researchers should work together to monitor the most likely trajectory of population change and assess its possible implications. In this connection, we need to ensure the continued production of relevant, updated, and accurate data. As we all know, the estimates that we do will only be as good as the quality of data provided. PSA recognizes some level of underreporting of vital events in their vital registration report, particularly death statistics in particular parts of the country, but they have done and continue to do a lot of interventions to improve the data quality. PSA has also stepped up its processes for data sharing. We therefore reiterate our call for greater collaboration among government agencies who collect similar data to come up with an integrated data as basis for planning. The different levels in the number of COVID-19 deaths reported by DOH and PSA is a case in point. We need to harmonize our statistics for better planning. So that ends my report, and thank you very much for your attention, and looking forward to more discussions later.
Thank you very much, Ma'am Grace. That's a quick overview of Demo 210 and 211. So if you have questions, please write them in the Q&A or in the chat box, and we will entertain them later. And now I'll call on to Miko Del Mundo to present your presentation, to give your presentation.
Yes, good morning. Thank you, Ma'am Elma. So I am Michael Del Mundo from the UP Population Institute, and I will share our study on excess deaths and births during the COVID-19 pandemic in the Philippines. So this study was done with my colleagues, Christine Briones, Manuel Albis, Michael Timbang, and Sani Afable. And special thanks to the Philippine Statistics Authority and the UNFPA. So for this presentation, I will start with discussing the excess deaths in the Philippines, and then we will go to our discussion on births, and then we will conclude with some key points and ways forward. So excess deaths. So when we talk about excess deaths, it is very important to first define what are excess deaths. So formally, excess deaths is the number of deaths from all causes during a crisis such as this pandemic, above and beyond what we would have expected to see under normal or pre-pandemic conditions. So estimating excess deaths is really important because it can quantify both the direct and indirect impact of COVID-19 on the mortality situation of our country. Now, when we talk about excess deaths, besides the confirmed deaths from COVID-19, we also consider the following situations. So we consider deaths of suspected COVID-19 patients who are either not tested or tested but with inconclusive results. We also consider increase in deaths in other causes, not just from COVID-19. We also take a look at the deaths of individuals who avoided or were not able to go to hospitals to get treated or who got less funding for treatment. And then last, we also consider the decrease in deaths in other causes due to lockdowns, mobility restrictions, etc. So here in this slide, I am showing the number of registered deaths in the Philippines from January 2015 to December of 2021. And this is the data here is as of 31st January 2022, and as such is still preliminary. And the gray bars represent the registered deaths pre-pandemic, that's from 2015 to 2019. The blue bar represents the registered deaths in 2020, and the orange bar represents the registered deaths in 2021. Now, we need to understand that mortality patterns and trends, they do not change fast over time. So they take time, they take years, even years to change. So it is not volatile. So any unexpected spike that we see in the registered deaths may be and most likely be due to an unexpected event, a catastrophic event, which is considered non-normal. So as we can see here, the orange bars for 2021 registered births is really above the levels from 2015 to 2019. Now the question is, are these excess deaths? And the answer is actually yes, we have excess deaths in the country. And as you can see here in this slide, the blue line represents the expected number of deaths under normal and pre-pandemic conditions. And then the yellow figure is the actual observed registered deaths. And as we can see here, especially in 2021, the yellow figure is above the blue line, which indicates excess deaths in our country. So the gap between the yellow figure and the blue line is what we consider excess deaths. So the next question is, where do these excess deaths come from? So of course, we are in a pandemic, and we know that a share of those excess deaths come from COVID-19 related deaths in the Philippines. So the data that we are using comes from the Philippine Statistics Authority, as recommended by the WHO under the ICD-10, which has 4 categories when it comes to COVID-19 related deaths. So what are these categories? So first is UO 7.1, which is COVID-19 virus identified, which are deaths where individual was COVID-19 positive as confirmed by laboratory testing, irrespective of the severity of clinical signs or symptoms. And then we have UO 7.2, virus not identified, which are deaths where the individual was clinically or epidemiologically diagnosed with COVID-19, but laboratory confirmation was inconclusive or unavailable. And then we have another 2, U10.9, which are multi-system inflammatory syndrome associated with COVID-19, including cytokine storm, Kawasaki-like syndrome, and then last, U12.9, which are COVID-19 vaccine causing adverse effects in therapeutic use. So when we look at COVID-19 registered deaths in the Philippines, we can see here that UO 7.9 and UO 7.2 are leading the way. And the story here is that in 2020, there were more deaths categorized in UO 7.2, COVID-19 identified, compared to UO 7.1. But come 2021, there were more registered UO 7.1 deaths compared to UO 7.2, which may be an implication of better testing capacity in our country. Now, for the other 2 categories, U10.9 and U12.9, they were included as categories only mid last year. So we only started using these categories around mid last year. And as we can see here, U10.9 and U12.9, the registered births under these categories are very few. Okay. Now, in addition to laboratory confirmed deaths due to COVID-19, excess deaths also capture COVID-19 deaths that were incorrectly diagnosed and reported, and also deaths from other causes attributable to the overall COVID-19 crisis conditions. And what we found is that excess deaths during the pandemic is not just COVID-19 deaths. In fact, we saw increase in deaths from other causes. So where does this notable increases come from? So we observe increase in deaths due to endocrine, nutritional, and metabolic diseases, which includes diabetes and malnutrition. Also, we saw increases in intentional self-harm and cardiovascular diseases. Here in this slide, we can observe a significant increase in the number of deaths registered under endocrine, nutritional, and metabolic diseases for 2020 and 2021, higher compared to what has been observed from 2015 to 2019. The same story goes with diabetes mellitus. We see for 2020 and especially in 2021 that the number of registered deaths for under diabetes mellitus is higher compared to the past 5 years prior to the pandemic. We also see that in malnutrition, especially in 2021, when we see a spike in the number of registered deaths under malnutrition, which is actually almost double what we have observed in 2015 to 2019. And then also for intentional self-harm, for 2020, we saw a huge increase. Okay, again, almost double what we have been observing in the past 5 years. And then last, hypertensive diseases. We also saw a slight increase in 2020, and then in 2021, where we see a large increase compared to the past years. So again, excess deaths is not just COVID-19 deaths. Okay, we also see increase in other causes such as what has been shared here in the following slides. Now we go to births. What is the story of births during the pandemic? So when the pandemic started, there were a lot of experts that were talking about this. What would happen to fertility? Now, some said that there could be a baby boom, which means more births due to less access to reproductive health services or contraceptives. Also because of more time spent together because of lockdowns, mobility restrictions, more time to conceive. But on the other hand, a lot of experts were also saying that there could be a decrease in births because of fear of infection. They would not like to risk themselves and their baby, themselves getting pregnant during this time of COVID-19. Of course, there's uncertainty about the future, both economic and their livelihood, increase in household work and childcare. And it could also be a result of decline in marriages during this time of the pandemic, and also could be the reason why we can observe decrease in births because of some delayed registration. So what happened in the Philippines? And as we can see here in the slide, again, the gray bars are the registered births in the pre-pandemic years, 2015 to 2019. The blue bar is registered births for 2020, and the orange bar is registered births for 2021. And we need to understand, before we look at this, we need to understand that the impact of the COVID-19 pandemic on births really can be observed by December of 2020, because it takes 9 months from a conception to birth. So if the lockdown started in March of 2020, then the first observed effect of the COVID-19 pandemic is from December 2020 and onwards. Okay? And yes, we know that the births are slowly declining. Okay, our fertility rate are slowly declining. But what we can see here, for example, starting from December of 2020 and 2021, okay, all the way to 2021, we see here a rapid decline in births, which is not aligned to the previous trend, the current trend of fertility decline in the country. So this is somehow a surprising, very rapid decline in the number of registered births. And we can also see here the monthly registered teenage births in the Philippines, where we also see that in 2021, it significantly declined compared to what we have observed in 2020. So why do we observe this trend in fertility? So there are a number of possible explanations, but according to literature, what has been established is that fertility preferences and fertility behaviors during crisis actually change. So for example, a study in 2010 saw that women fertility preferences changed during the 2008 Great Recession, with the majority of the women interviewed saying that they can't afford to have a baby right now because of the recession. So if we can recall the 2008 Great Recession, which started in the US. And then a more recent study in 2020, wherein they looked at the women and couples' reasons why they would forego or delay pregnancy during the COVID-19 pandemic. They found out that that is mainly due to the concerns about their own and their infants' well-being, the prolonged economic uncertainty due to the risk of being unemployed, and increased childcare and child education demands for women who already have children, among others. Of course, what we are seeing, the decline in births, could also be, and this requires further study, of course, but this may also be because of significant decline in marriages during the time of the pandemic, and it could also be an artifact of late registration of births. But then again, we need to have further studies on that. So what are the key points and ways forward as a conclusion to this presentation? So one of the clear effects of the COVID-19 pandemic is the increase in the number of deaths experienced by the country. And we saw a while ago that there was excess deaths that the country experienced. And these excess deaths is not just COVID-19 deaths. Yes, COVID-19 deaths play a part, is a share of excess deaths, but also there's been an increase in deaths from other causes. And namely, these are due to endocrine, nutritional, and metabolic diseases, which includes diabetes and malnutrition, intentional self-harm, and cardiovascular diseases. Another effect of the COVID-19 pandemic is the decrease in the number of births in the country, as what we have observed in the charts a while ago. So what are the ways forward? To have a clear picture of the mortality situation due to COVID-19, we should consider not only COVID-19 deaths, but also the deaths from other causes, which have risen during the time of the pandemic. This would ultimately aid our government to design data-driven interventions, focusing on mortality. And even though the Philippines is currently experiencing a decline in births at present, there is a need to further study and investigate women's and families' longer-term fertility preferences, and to prepare for a possible trend reversal after the pandemic. We still don't know, but there could be a possible trend reversal after the pandemic. And lastly, efforts should be placed to find and register those births which have not been registered or will be late registered during the pandemic, to complete the picture of what happened to our births during this time of COVID-19. So that ends my presentation. Thank you very much.
Okay, thank you very much, Miko. That's a lot of numbers that we need to digest, but you made it look so easy, I have to say, no? So I see some participants raising their hands. So please, if you have questions, write them in the Q&A or in the chat box. We will entertain them later. So COVID-19 pandemic is not the first pandemic that the world experienced, though none of us were present during the first two. We are happy that our scholars who research on this topic. And so now we will hear from Professor Francis Gialogo. He will take us back, no, several centuries back during the cholera and the flu pandemic in the Philippines. Sir Francis?
Thank you, Elma, and thank you to PCPD for inviting me in this congregation. As Elma and Grace would have known, I'm always like odd person out in these types of gatherings. Now, when I present some of my research findings to groups of historians, they would rather shy away from the rather quantitative dimensions of my research. No? On the other hand, when I present this to an audience like this, I always feel insecure whether my quantitative or my qualitative narratives of the social history of the experience of the pandemic would make any sense or relevance to them. No? So as Elma had already mentioned, I am a historian, and actually when I studied for my PhD in Philippine Studies, I really I was really very conscious not to enroll in PhD in history, but in Philippine Studies, for me to be able to present a program wherein I can enroll in demography courses, which became quite problematic for my program advisor because this has never been done before. And unfortunately, nobody else followed me after this. So it's quite a lonely type of field of specialization. But at any rate, I would like to share my screen and my research. Initially, I intended to focus on both the influenza pandemic of 1918, 1919, and the cholera pandemic of 1903 and 1905 for this occasion. But later on, I limited my focus on influenza for lack of time and for the sake of brevity. So the title of my presentation is Influenza and Empire, the 1918 Influenza Pandemic in the Philippines, and the challenge of Philippinization of the American public health programs in the country. So just a background on the influenza pandemic, it was estimated that 40 million people died in the pandemic after a 2-year uh, surge. Influenza killed more people than those who died in First World War. Now, just to give you some context, the 1918 influenza pandemic came at the towards the end of the First World War, which lasted from 1914 to 17. So the armistice was being negotiated and signed during the time, and the soldiers were returning back to their countries. That's when the pandemic happened. The influenza in 1918 killed more people in 24 weeks than those who died of AIDS in its 24 years since the outbreak of the AIDS pandemic. An interesting thing is that, and this can be one of the reasons why we shy away right now in naming our even variants or viruses to particular nationalities or place names, precisely because of the danger of either xenophobia or people becoming more confident in going out and not following the health protocols precisely because they don't belong to a particular group. Initially, we some of the media personalities were calling COVID as the Wuhan virus, and we had the South African variant, the Indian variant, or the UK variant. Now we renamed it to a more politically correct and less more neutral alpha beta or original virus. Because of the lessons of influenza, it was mistakenly called Spanish flu, and historians do not call them Spanish flu precisely because of the political incorrectness of the term and historical incorrectness as well. It was not located in Spain initially, but Spain, was being a neutral country during the First World War, was reporting it freely, unlike the combatant nations of the United States, UK, France, Russia, Austria, Hungary, and Germany. They tried to suppress reportage on the outbreak of the pandemic in the respective countries for fear that this may weaken their positions vis-a-vis the war efforts and the armistice that may come later. So there was a great degree of othering, saying that it's their disease and therefore we cannot be affected by it anyway, or a great deal of, as I said, xenophobia happening. It's a particular nationality's disease and therefore we should discriminate them. So in many countries, it was called many things. Even in Southeast Asia, the Malays called it a Chinese flu. The Chinese in Singapore and Malay Peninsula were calling it a Malay fever. The Britons in these countries were calling it a Malay, an indigenous flu. In Indonesia, it's a Dutch fever, and so forth and so on. Just like COVID, the 1918 influenza pandemic was a 3-wave pandemic. It happened in surges and waves. The May to June pandemic was relatively milder in terms of mortality, but very high morbidity rates. The October to December 1918 wave was actually the most virulent and registered the highest mortality. The February to March 1919 was a wave that somehow signified the dying down of the surges. It was observed to be virulent among the young adult population because most of the elderly were not going out. The children were also restricted in terms of mobility. So the laboring classes, the laboring ages were the ones who were going out and therefore became more exposed to this. In the Manila Times, for example, some of the familiar reportage that we had seen in the past 2 years were already being reported more than 100 years ago. No? Grave diggers were even in short supply. Medical doctors and practitioners were themselves affected. A number of medical frontliners became ill or unfortunately succumbed to influenza. The very first Filipino director of public health, Vicente de Jesus, himself fell ill. Farm workers failed to harvest the rice and sugar. Laborers failed to report to work. So there was a great deal of economic dislocation that happened. The effect was that because of this, the high cost of living, not only in the urban areas of Manila, Cebu, Baguio, and Davao was observed, but also in the countryside, wherein food supplies became short. And as a result of this, the inflationary pressure on these became observed. No? Overcrowding in most hospitals and the lack of government support and budget. No? Unfortunately, in 1918, the 1916 Jones Law has just been implemented, and as a result of this, there was this equivalent of our salary standardization law, lowering the salaries of even nurses, pharmacists, and most especially doctors. No? And the healthcare and the hospital system was not expanding at the time. No? There was international involvement during the time, but because the WHO has yet to exist, there was a lack of international coordination in this particular respect. So as I mentioned, it came via waves. In the Philippines, you can see in the 1918 census, no, that most of the deaths actually occurred in the months of October, November, and December. The second wave affected most of the archipelago, while the first wave was generally confined to Luzon. Most of the victims were under 40 years old and affected 45 to 55% of the population with 2.5 to 3% case mortality. I would just like you to present a very crude map, no, of these waves. So the first wave affected the core provinces near Manila, but the second wave affected most of the archipelago. One should deal with suspect the data from the Cordillera and Mindanao. It's indicated in all white here, but this should not be taken as proof that there was no influenza deaths during the period. It may be a function of underreporting or misreporting because there were many newspaper reports and the narratives from the ground that there were indeed high cases of fatality and mortality figures in these regions. So again, no, the quality of data is always very important, not only for contemporary demography, but also for historical demography as well. Some of the official reports of the Bureau of Health mentioned the depletion of personnel through resignation, reassignment, and war involvement, quite familiar. No? There were debates on scientific and medical reports whether public health officials should come to the fore as the leader in combating this disease, or whether we should let politicians do the leadership. No? And there was a great deal of infighting amongst the bureaucracy. The Health Service Advisory and the conclusions made by the Bureau of Health, some were actually scientifically based, but some were, suspect whether these were to be believed or not. No? So these were some of the findings of the Bureau of Health after the pandemic. As you can see, some of these, some of those in public health can easily relate that some of these are really scientifically based, but others are not really that much believable. But one thing that's certain is that it also created an undercurrent of narrative. No, some of those who were affected by the pandemic, not only by cholera but by influenza, but also by cholera a decade before, uh, found the experience a rather political, as having a rather political undertone. This is one of the folk narrative that circulated during this area. I tried to translate this into English, but this was a prayer um, for the title was Panggagaling sa sakit ng cholera, no? And then retold as Panggagaling sa sakit na influenza. It's as if the people were more fearful not only of the pandemic, but also of the sanitary guards, the wagons, the abusive inspectors, the unknowing medical practitioners, no, the hardships and pains of San Lazaro Hospital. And then it became very, very anti-colonial and anti-American. They were fearing from the drunken Americans, the abusive Americans, then the mandarambong, no? Hanggang ngayon, natatakot pa rin tayo sa pagbabalik ng mandarambong, the jingoists, the highwaymen, the oppressors, and all. And then the popular saying was advancing the idea that perhaps social independence and equality may be the way out of this misery. No, and just like most prayers, it will end like in a Latinized form of Tagalog saying lahatur ng mga bagay-bagayan tur sa letanyatarum ay siyang larawatum ng bayaning Pilipinarum. Alam naman natin, no? We can easily understand that. Per kahirapan rebentatum, no? It's always not only exclusively against the pandemic, but also against poverty and for the betterment of the people. This also was caught in the narratives of even the officials who tried to popularize the campaigns, no, for the people to follow. They presented their health protocol campaigns in somewhat religious manner. No, these were in folletos, in leaflets being distributed in not only in English but also in Tagalog and in other Philippine languages. No, in the 10 Commandments, in order not to be sick. Again, no, we should take it with suspicion. Some are really scientifically based, but others may be, more like conventional, non-scientific based mitigation. So in 1918 census even, no, there was an essay, because the census back then were actually composed not only of figures but also of scientific papers and essays, even historical pieces and political narratives. There was this essay highlighting the popular reception of people vis-a-vis the pandemic. The title was Ginamot ng Ulol, Pinatay ng Marunong, Cured by a Fool, Killed by a Wise Man. Highlighting the dilemma of public health officials in dealing with popular consciousness and the degree of acceptability amongst the population vis-a-vis the public health protocols being implemented. So there was a great deal of denial, not only amongst the people, but also amongst the public health officials. Initially on, while the other countries were saying that perhaps it's not their disease, Philippine public health officials readily and right from the outset declared that it was just a Philippine trangkaso, and therefore we should not take it seriously. There was this misdiagnosis because unlike now, we already developed a vaccine. Initial medical studies were, trying to figure out, a bacteria, for influenza. Only later on that they found out that it's not a bacteria but a virus. So even amongst the general population, they cannot distinguish the difference between bacteria and virus. What more for the scientific community who were uh, uh, trying to figure out the process, of teasing out influenza as a bacteria. It will take, I think, more than 20 years before they can develop a vaccine on this, when they diagnose it correctly, eventually. There was also a great deal of economic nationalism between and amongst the different nations. They thought that perhaps closing their borders or not letting their countrymen out may be not a good deal for their economy. At the same time, the political concerns, particularly for countries in Asia, Africa, and the Pacific, when the colonial masters were holding the fray, and most of the medical practitioners were uh, members of the colonial bureaucracy as well. So there was this great deal of mistrust or association with colonial occupation and public health implementation. Some security considerations. Initially, the Philippines was actually trying to mobilize troops for the war efforts in World War I. We already had training camps in Camp Claudio near Pasay, no? So we collected volunteers from all over the archipelago. They were training in Camp Claudio when the influenza pandemic happened, making Camp Claudio one of the epicenters of the pandemic. So when these troops who were never sent to Europe for combat were sent home, because the armistice was already signed before they went to combat, they carried with them the virus, and making it more easy for the virus to spread all over the archipelago. Some of the cultural and race issues, ethnic relations and class relations, I mentioned already before. One should also consider the cultural differences with regard to perception, attitudes, practices, and knowledge about the disease is spread, and the measures of control to be adopted. As I already mentioned, some of the class-based perceptions or perceptions between and among the colonizers and the local indigenous peoples should also be reckoned. And therefore, if we are to write the narrative of the 1918 influenza pandemic, one should also recognize that the pandemic had many discourses, multiple sources, contesting meanings and divergent approaches, contending forces and different interpretations to the pandemic. In one narrative, there was one report saying that most of the poor Filipinos were trying to go out simply because while they were fearful of the pandemic and dying from the disease, they were equally fearful of hunger and economic dislocation. Parang ang sinasabi nila, mamamatay ba kami sa sakit o mamamatay kami sa gutom at kawalan ng trabaho. Again, amplifying the current experience that we have right now. So one can also look at the possibility of this cultural dimension with regard to the idea of wellness, kagalingan sa Filipino, and these notions of kagalingan, kawalan ng sakit, the very notion of sakit, pasakit, it's not only related to the disease, but also pasakit as having the experience of harsh implementation of some of the public health or government policies vis-a-vis the pandemic. Or kagalingan, it's not only the absence of disease, but also the presence of knowledge of being able to cope with the situation in the pursuit of wellness. In Filipino, when we use the prefix ka for kagalingan, it indicated the communal and community experience. So therefore, kagalingan is not only an individual experience, Pwede kang walang sakit, pero kung ang kapamilya, kapitbahay, kabarangay mo ay may sakit, wala ka ring kagalingan. So the very idea of wellness and public health and science had permeated already this particular discourse that should be redefined and reassessed even to the present. How do we deal with all of this? How do we deal with popular consciousness? What are the narratives that are being created out of this. So yun lamang po, marami pa sana akong ilang mga datos tungkol sa mga nakaraang pandemya, but since we only have a very limited time, I should end here. Thanks for inviting at magandang umaga sa ating lahat.
Maraming salamat, Doc Francis. Kahit sa amin, we always find this interesting, this historical, information, and we see yung link ng importance din ng datos talaga, no? And we see it na kahit yung historical and contemporary demography, that's always an issue. But I'm sure there are very interesting questions already I'm seeing from the Q&A, but we still have one presentation, or it's more of a reaction naman from Yusek GP Perez of the Commission on Population. Doc GP?
Magandang umaga sa lahat. Thank you, Professor Elma. Thank you, PCPD, and my co-presenters out here for this morning session. I truly appreciate all the previous discussions. Let me begin by saying that the only reason we're able to have this discourse is because the PSA has been reporting through the civil registration system the incidents relative to the pandemic, no, in a time frame that is sometimes too fast for us to absorb, no. For example, the data being presented by Professor Grace, Professor Miko, all refer to January 31 release by PSA. But 3 days ago, they made another release on births, deaths, and marriages. So I will annotate by also updating what Professor Miko and Professor Grace said, particularly about the current data. For example, and I'd like to take note also on what Professor Mika was saying. How complete is this data coming out of PSA? No, I think they allow for late reporting. That's why they say the data they're coming out with is preliminary, because a month or two later, the numbers may change. But the ones that change usually are the last 2 or 3 months. For example, the latest release of PSA is already up to December 2021. But the numbers in December are probably a third of what they will eventually be. So you might say the numbers for the first 10, 11 months of the year will probably not change very much. But the last month of 2021 will still change quite a bit. Now, I'd like to begin by discussing the fact that COVID did not have an effect, a great effect on birds, including teen birds, in 2020. The effect was apparent, as Professor Miko says, from December 2020 onward. And I appreciate the graphs that he showed, which were showing really pandemic effect. But I would also say there is also the effect because of the caused by the changing behavior of the population. Number one, the fear that was cited before in previous cataclysmic events, the fear, the well-being, all of these played into the decisions of couples to have or not have children during the pandemic. And I think most of the citations are valid. So what happened in 2020 also showed, I would propose, already some excess deaths. Excess deaths caused by COVID-19 took up 5% of mortalities in 2020. And that 5% can be labeled as excess because they were not present in March 2020. So it's a new disease that came up, and all the deaths from that, 30,140 of them were all caused by COVID. And there we have a kind of disconnect in our thinking, because DOH was reporting at the end of 2020 only 9,000 deaths from COVID. But the data from PSA will show that COVID had 80 mortalities in March, and it kept on increasing up to December of 2020. So that eventually it made up 6% of the mortalities in the 9 months that it was affecting the population. So that is an excess death already for 2020. The birth decline was seen already in January 2020, not caused by COVID, but the decline in births only happened in December. So you might say 2/3 of the births in 2020 were probably from previous behavior, previous setting where there was no COVID. It was only the births in 2020 that in December 2020 that were affected. So it's more interesting really to look at the situation in 2021, which is one full pandemic year. And I am I'd like to add to what Professor Grace is saying. She was quoting around 360 births in 2021. PSA is now reporting 407,000 or almost 408,000. The deaths were around 680,000 as of in their last report, a little over 700,000. As 3 days ago, PSA is reporting that the mortalities in 2021 were 129,000. It is the highest number of Filipinos dying in a given year. If you translate that into percentages, that means the mortality rate in the Philippines in 2021 was 7.54%. And the birth rate was 11.25. So the difference, as was showed by Professor Grace, is even narrower at around 3.7%. No, or the difference of about 407,000 additional births on top of the mortalities. So that is the natural increase, only 400,000 in 1 year. It's worth noting also that the highest mortality we ever had in the Philippines was 19.5% in 1926. While the highest birth rates we have had were back, the lowest birth rate we had, the highest birth rates the highest difference birth rate we had was 1940 and 1928 at 32%. So we are quite ways from those days. Now, going back to COVID, as Professor Miko was saying, if you look at the PSA data, today we have 127,352 deaths from COVID. However, if you look at the DOH data, there's only 56,000. And that is where DOH is saying the case fatality rate for COVID is 1.54%. But if we use the data from PSA of 127 deaths, it will add 2% to the case fatality rate. The actual case fatality rate based on PSA data is 3.48%. Now, people might say, why is there a difference? Why doesn't DOH and PSA reconcile? They are actively trying to do so. But the reconciliation is only to confirm the mortalities among those with identified COVID. No? PSA cannot change numbers of deaths that they are reporting by law. So whatever reconciliation happens will not affect the 127,352 deaths already from COVID. In 2021, 96,000 people died from COVID, with December still not fully counted. That took up about half of the excess deaths in 2021. And Professor Miko reported some other causes of leading, but for public health purposes, no, for us it's important to note that three of the leading causes of death outside of COVID also increased. Hypertension has increased, deaths from hypertension, deaths from cerebrovascular disease, and diabetes mellitus. They're all in the top 5 causes of death. And they contributed the other half. These are collateral deaths from COVID. And the reason why I call them collateral is because people with these diseases are chronically ill and need continuing care from the health system. However, if the health system is unable to cope, no, in treating hypertensives, providing care for those who are in danger of having strokes, and care for diabetics, that is where we have seen an increase in these diseases. On the other hand, neoplasms, cancer, has gone down. And again, I would attribute that to the weakness of the health system, because hospitals are not completely available for diagnosing cancer. For example, I was talking to another doctor who was saying, I wanted someone to have a test on cancer, but it was not available even in the biggest hospitals in the country. So there is a lack of care for those 3 diseases, and those with potential cancers are not being identified. And that shows a significant impact on the health system, no? That is going to be, to take some years to catch up with. So I would think that it's important in this election campaign for candidates to talk about why is there such a high mortality? Why are neoplasms going undetected and killing probably others who die from those other causes? And that should also impact on the local health system, because the local health system is the one that cares for these people at the primary healthcare level. If primary healthcare is absent or unable to cope, you will just see people dying at home more and more, or dying in hospitals with intractable diseases. So these are important matters for the country to consider as we enter the 3rd year of the pandemic, and we need to adjust to improve the way our health system is able to cover both COVID and non-COVID health problems. We cannot just deal with COVID and forget about the rest of the health problems of our population. So it has a very important impact on population health. Now, it was also commented that we don't know what will happen with births after the pandemic ends, no? Or maybe in this 3rd year, will people continue to avoid giving birth, or will there be a rebound, an increase? I would say that there are 2 matters that go against a complete rebound in birth rates. Number one, more people are using modern family planning. We have increased the numbers to more than 8 million Filipinos, where there were only 4 million Filipinos using family planning a decade ago. Second, the economic crisis will continue to have an impact on our population, and as shown by Professor Miko, economic concerns also impact on fertility decisions. So I believe there will be a rebound, but probably not to the fertility levels pre-pandemic. So people's behavior will probably change because of this pandemic. And also noteworthy is because of these birth rates, the PSA announced yesterday that the total fertility rate of the country based on the 2020 civil registration is now 1.8 children per woman. And that is lower than what we thought it would be in 2020. We thought it would be around 2.5 children per woman. So we need to have the validation, not really a validation, but a confirmation or a correlation with other surveys that will indicate truly whether we have entered a demographic transition. And as Professor Grace noted, we can enter the demographic transition, but we do not necessarily get the gains from this demographic transition if we do not have the policies that will increase wages of workers, living wages that will increase to living wage, not minimum wage, that will lead to more employment of young people, that will lead to more participation by women in the labor force, and increasing financial literacy among our senior and other citizens. So there must be a comprehensive set of policies to take advantage of this transition. And that is something that the next administration or the politicians could be talking about. So I end at that point. Thank you very much. Thank you to all the presenters. Magandang umaga po mula sa Dagat Pasipiko.
Okay, maraming salamat po, Yusek Perez, sa inyong reaction. So now let's go right into the questions that we got from the Q&A. And una muna, I tried to group these questions kasi some of them are similar, no? Una muna kay Dr. Francis Dialogo. Have we seen the worst pandemic ever, or this is just a prelude to more catastrophic one? And another question is, do you believe in the phrase history repeats itself?
Yeah, doon sa presentation ko, I noted that despite the limitations of the data in the 1918 census, the deaths, case mortality deaths related to influenza was recorded to be somewhat in the 90,000 figure. At the time when we had only around 11 million population. So if I don't know if this is something that demographers do, pero if we project from 1918 to 2022 with 110, more than 110 million, anong ibig sabihin no? Mga 900,000, tama ba? Historian ako, hindi ako magaling sa mga 900,000 yung namatay kung sa kasalukuyan naganap yung influenza pandemic. So definitely the past pandemics were worse because the medical practice was also quite limited. Research was also limited. International cooperation measures were also relatively absent because of the absence of WHO. There was Asia Pacific Medical Association or something like that. But these were actually initiatives of the colonial powers, the Americans, the Britons, the Dutch, the French, who were trying to protect their citizens in Asia and the Pacific, not necessarily the local inhabitants. No? Actually, the 1903-05 cholera pandemic was worse, even, because it came at a time when the Filipino-American War was just drawing to a close. So we still have rebellions all over. Concentration camps were being put up by the Americans. Again, no, pagsama-sama yung mga tao, and the outbreak was ongoing, so it became even harsher. But just like now, economic dislocation was pretty much present. No? So we have seen the wars, but in previous pandemics, even globally, for example, the bubonic plague of the 13th century, the cholera pandemic of the 16th century started in Latin America, and many others. No? Cholera visited the country as a part of a pandemic in the 19th century for almost every decade. No? And if we plot, for example, the mortality figures at the time, talagang unbelievable. No? In some of the wars, for example, in 1867, some towns had 40% of their population dying as a result of cholera. So we never had that. No, even with the most serious surge in I think Delta, no, in COVID. So we have seen the worst, but that should not make us more, complacent, about the situation. We should always be vigilant about this health concern. History repeating itself. As a historian, I don't believe in that dictum, but I believe that we can learn a lot from history. Because the objective conditions of 1918 may be extremely different, as I mentioned, no? Compared with what we have right now. Even 1903-05 cholera pandemic, or the 1867, the worst cholera pandemic that we had in recorded, with significant recording of the experience. These were wars, but we should be learning from its lessons. No? Not necessarily having to repeat it, because again, the objective conditions were different. So yeah. Natuwa ako, may nagtanong din sa history paper.
Actually, there's another comment. Isusunod ko na lang din that maybe this webinar can be a start for another documentation of the Philippine COVID history.
Yes.
Happy you're still there.
Yes, sana nga. Yeah, looking forward.
Yeah, saka kung meron kaming mga estudyante sa demography that, historical demography is another interesting field to explore. Okay, a lot of questions that we got are about is on data, no? And I will try to summarize them. For example, there's one from Ms. Navarro. How reliable is the PSA data on deaths and births especially happening in Muslim community? And may mga ganun kasi yung the discrepancy between the DOH mortality data and the PSA data. What can explain for that discrepancy? And also, Miko, there's question about age and sex disaggregated data from the births and deaths registration, if it's possible. And yeah, if Ma'am Grace or Miko can answer about data quality and data issues.
Okay, thank you, Elma. So yeah, you're correct. As I mentioned a while ago, the quality of our estimates will only depend on how good or how accurate the statistics are, right? And I think PSA, to a certain extent, has admitted that there are certain limitations of their data. Like even before this webinar, I was in conversation with one of our former students who's working with the civil registration system of the Philippines. And I was asking her, why is there a difference between the projected population less than 1 and the live births? Over the years, it's just 1.8, 1.7, but you have something like, 2 million there in the projected. And she said that it has something to do with under enumeration. So I think for the clarification of the processes that they do, they allow for late registration until March. Okay, so all those births occurring within a year that are registered until March the following year are still included. But even beyond March, there are still those that are, coming in late. No? So marami pang late registration. And we know that the reasons for late registration would vary. And it was made more complicated during this pandemic because of, the the offices are closed and access is difficult, no? So yun ang mga reasons, but especially with death statistics, no? There's also it's also very problematic, especially in particular areas, and I agree with one of the comments dun sa MARM area because of their culture na dapat mailibing na ang ang namatay within 24 hours, no? And so ano yung motivation nila to register that deaths kung wala naman silang makukuha, no? Na, for instance, wala naman silang benefit for using that death certificate. So those are some of the reasons why death registration is kind of low. But as I've mentioned, they are doing a lot of interventions to improve upon the quality of our birth registration and death registration, particularly in certain areas. And we really appreciate all those interventions. So, pero talagang it needs education. Maganda yung mga initiatives nila, like requiring birth certificates to be submitted upon enrollment of children in kinder. Pero that help a lot in terms of improving the registration. Pero, meron pa ring problema sa other areas. So I think we will just continue working on improving the quality of data because we really need information. Tignan mo na lang yung tatlo kami presenters, si Miko, si Yusek at ako. Iba-iba yung estimates namin, no? And because magkakaiba yung results. Like 3 days ago, of course, yun yung hottest, no? That's the most recent from Yusek. So we need to really look at our data so that we can make more accurate estimates and make our planning better. So thank you, Elma.
Thank you very much. How about the discrepancy between the mortality data of DOH and PSA?
Yes, I can answer that. So the DOH and the PSA may discrepancy with the counts because DOH uses a surveillance system which are counting yung deaths from COVID-19 positive from RT-PCR test, while PSA uses yung recommendations by the WHO using ICD-10, which includes the 4 categories which I presented a while ago, yung 07.1, 07.2, 10.9, and 12.9. So that is the main difference between how a DOH counts their deaths and how PSA counts COVID-19 related deaths.
So is there
Professor Elma, can I add to that?
Yeah, Doc GP.
Actually, DOH and PSA use the same, all the 4 categories on ICD-10. So, and mainly PSA is reporting on the deaths with COVID unidentified and deaths with COVID identified. DOH and PSA are working on the COVID identified. And the numbers, as was shown by Professor Miko, dumami yung COVID identified in 2021. And that is where they're reconciling their mortality data. However, yung COVID unidentified as a classification was higher in 2020. Tapos correctly, Professor Miko said bumaba, but still significant, 23,000 pa rin yung unidentified COVID. Now, what is the difference between, there are 3 basic ways people work in the clinical setting on COVID. First, you have the suspect COVID. Yung suspect, they fit the case definition, but you still do not know whether it's truly COVID. You have to have a lab exam, you have to look at them clinically, and finally get a COVID test. Not all will come out positive in the COVID test, no? Or maybe they were not able to do a COVID test because they did not have access to RT-PCR. So many doctors rely on clinical findings and some laboratories that indicate COVID. So that is called also a COVID death kahit hindi siya positively identified. And that is why DOH is only counting the positive COVID identified. PSA is adding those who are not positively tested. That is the reason for the discrepancy. Also, the PSA is getting reports from maybe 40,000 practicing doctors who are writing the death certificates. DOH is only getting a small number of that, and only if the doctors report to the COVID Kaya system. So DOH is inherently incomplete. PSA is the most complete data set. However, if we apply the PSA case for the number of cases, 127,000 deaths out of 3.6 million cases, the case fatality rate in the Philippines would be 3.48. That would make us the country with the third highest case fatality rate from COVID. I think Mexico is one and Colombia is probably number one. Indonesia case fatality rate is 2.7. So we would have an even higher case fatality rate if we use the PSA data to determine case fatality rate for COVID. And that is something policymakers in DOH and maybe in other government agencies have to look at, because they're not seeing the complete picture if they just look at DOH data.
But question lang, Doc GP, ano yung data ginagamit ng other countries like Mexico? Is it the
I presume they use the same WHO data. Actually, it was DOH that asked PSA to use that classification, because it was announced by WHO, I think in May 2020. So since May 2020, yan yung classification na ginagamit ng lahat ng bansa.
Okay.
Now, whether the countries are reporting out of a system like DOH, or countries are reporting from civil registration, that I cannot verify.
Okay.
But I only know our situation here, where there is that difference between the civil registration deaths and the DOH deaths. But inherently, the DOH report is a subset of the PSA data.
Okay, thank you. So more on data muna, no? I will just point out yung mga question dito about sex and age disaggregated data. Like for example, Mr. Ferdinand Pagaw is asking Dr. Cruz, do we have data on deaths for school-age children?
Yeah, I think para official, sir, pwedeng mag-email na lang tayo sa PSA, no? Para they will also give it, anyway, they will release the data to you if you make a formal request. So, thank you.
And Miko, another question on excess deaths from other causes by age group. Do we have that? And how does it differ with COVID-related deaths?
I'm sorry, Ma'am Elma. Can you repeat the question?
We have data on excess deaths from other causes by age group, disaggregated by age group.
We are still working on that.
Okay.
We're not yet done on that. Yes.
Yes. And there's a question from Mr. Benigno Agbayani. I saw deaths stratified by age group 2020 to 2021 by Professor Del Mundo. Do you have an updated version of this?
Yes, but it was not included in the presentation. But we updated it. But the story stays the same, that the vulnerable age group are those that are elderly age groups. Yeah.
Do we have a projected excess deaths from March 2021 to March 2022?
This was done by our team in the past, but we need to revise that because of the new data, new information that we have. But as of the moment, we have not done our forecasting models yet.
But for what's the latest forecasting model you have? For 2021, do you have?
For 2021, we did a forecast up to 2022, but we only use data for until May 2021.
What's the
That's
number?
why, okay.
So,
I can check. I can check later. I
Yeah.
can go back because for us right now, ano na pasok na yung aming model, pasok na yung aming estimates dahil yung data na ginamit namin was way old, up to May 2021 lang.
okay. So because there's also another question by Mr. Agbayani. So now let's address the elephant in the room. Ito yung most common questions that I saw, now I'm seeing in the chat, no, and in the Q&A. The link between vaccination and deaths, because there's an observed increase in the number of registered deaths in March when vaccination started. What's your take? What could explain for this? Is there a relationship?
Well, Professor Elma, we already released 2 months ago, almost 2 months ago, our analysis of PSA mortality data. And it shows that deaths, it's simply because DOH reported 9,000 mortalities at the end of 2020. So it seems as if COVID was not affecting the population that much. And 2020, wala pang bakuna. Yet, 5%, if you look at PSA data, 5% of the deaths that are already, I would consider excess in 2020 were caused by COVID and by nothing else. And by March, you saw, of course, the next wave coming on. And if you track probably the number of vaccinations in March, which are only a few 100,000 probably, because it only started to peak in the middle of the year, they will not correlate. The number of deaths continue to be because of COVID identified or COVID unidentified. And I think Professor Miko's graph will show that. It has no correlation with vaccination. And the vaccine, the item number 4 in Professor Miko's classification, no, yung death from adverse effects of the vaccine, there were only 2 noted by 2 deaths noted by the doctors in most of 2021. As of November 2021, there were only 2 deaths because of adverse effects. So there is really no basis to assume that. But I think it's easier to presume that the deaths are because of COVID than from an external factor, because that is what the doctors are seeing. And the other deaths, excess deaths, are due to the weakness of the health system. That is more plausible than thinking about an external factor for which there is no evidence. No deaths have been attributed to that. So these are all conspiracy, or maybe even, it's similar to 1995 when the DOH started giving, was very strong in providing immunizations to pregnant women. And some people spread the word that, yung nakadagdag doon sa injection na yon was something made in India that was abortifacient. And some people believe that.
Yeah.
And as a result, bumagsak yung boto para kay Senator Flavier during the election because of that. And people can believe that, but there is no evidence, really.
Thank you, Doc GP. Miko, can you say something about this also?
Yes, I think that we have to be actually extra careful. From a statistical point of view, you can have a correlation, but this correlation can be spurious, meaning there is really no causality. And of course, we need to remember that correlation is not causality. So we need to be careful with our conclusions based on just a correlation coefficient that is based on a mathematical relation between two X and Y variables.
So in layman's term, there's no enough evidence.
Yes, or in layman's term, more studies. If there really is, there should be more studies on this.
Yeah.
Not just based on one correlation coefficient.
And also, I think it needs to be pointed out that we don't have data on vaccination. We don't collect. No? So you cannot establish na yung deaths is because of a vaccination. Sa death certificate, din naman tinatanong niya, vaccinated ba itong namatay? The same way that
Yeah.
DOH is not also asking.
Professor Elma, I'd like to explain. There's a system in the public health system.
Mhm.
They call it the AEFI,
Mhm.
adverse events following immunization. That is in place. No? If within 24 or 48 hours you have an adverse event following your vaccination, there should be a report made to the health system, and the DOH will farm out someone or a team to establish the causality based on history of the patient, maybe even on laboratory and other findings. Now, of course, that was easily done when we had the EPI for 2 to 3 million children. But now with 100 million or maybe 70 million getting vaccinated, it's really more difficult. But there is a system to do that, and I hope DOH is activating that whenever an adverse event is reported. Ang problema sa social media nire-report, baka hindi nalalaman ng DOH.
Yeah.
So they cannot act properly if they are not officially reported.
Okay, thank you so much. Siguro yung isang question dito, again to go back to that important issue, no? So may isa kasing tanong dito is whether you believe that there is a link between these excess deaths and vaccination. So maybe we can, just to answer that question and just to put it out, no, as demographers, as data crunchers, whatever you call, however we call ourselves, and maybe kahit si Doc Francis Dialogo, no? Maybe you can have, can you also clarify, halimbawa, ng 1918, when did the vaccine, when did we get the vaccine? At ano yung naging epekto ng deaths due to cholera or to flu, because we don't have that before, no? We don't have the vaccine.
Yeah, they never had that no until after more than 20 years. So we cannot really say that the vaccine ended the pandemic.
Mm-hmm. Nico?
Yeah, hello, Professor Elma. Historically, they had a serum-based solution to the Spanish influenza. This was developed in the US, but the impact was minimal. But they did have that, based on the serum coming from those who had been cured. So that was among the early efforts to develop a vaccine.
Yeah. Okay, thank you. Miko, what's the link? Is there a link? Kung wala.
My decision is always empirical based, data driven. As of the moment, the data that is going to help us establish the link is not really there. So I cannot really say that there is a causality.
Okay.
So as of the moment, based on the data that we have, no.
Yes, Dr. Cruz.
Yeah, I agree. I want to defer because this to the medical practitioners, because they would know, no, and we need more data to establish whether the link is there. Because as of now, I agree with Miko, if you look at the data, there's none to establish the direct causality. So I also reiterate what he said earlier, that we don't confuse, association with causality, because that's why we need a better understanding of statistics, so that we know that causality means this is causing the other variable. When you say that they are just associated, one variable increases, the other also increases, but they are not necessarily linked. Okay? So parang ganun lang yung dapat sa intindihin natin, just because na nag-increase yung deaths when we were doing all this vaccination rollout doesn't mean that one is causing the other. No? So we have to be very
another issue that we can also put out, no, is how many deaths were averted because of vaccination. That's the one of the reasons also why I asked Nico. They did an estimate of excess deaths in 2021. Kung na-ano ba yun? Na-achieve ba yun? sumobra ba doon? Do we have data? Or can we say something about that? Deaths avoided because of vaccine. We could have more deaths if we don't have vaccine now. No? Miko?
Sorry, ma'am. Hinahanap po yung akin. But we honestly, the team has not looked into that. Because what we did was just to forecast the excess deaths last year, but we did not calculate the deaths averted. Yeah,
the actual deaths. Okay, maybe that's another issue that we can explore. We still have 9 minutes before 12, so I don't know if I have answered all the questions in the Q&A, but I will try. Okay, you're not telling the truth and you know you are not. Okay, whatever. So, do you think the government loans budget for COVID-related initiative justified given the data, information, and conclusions presented here?
Is that being asked of government?
Yeah, so I think I will ask.
Can you repeat the question?
Do you think
what was the question?
Loans that or budget for COVID-19 or COVID-related initiative justified given the data and information or conclusions presented here? Ibig sabihin siguro, we have increasing excess debt, so and we have so much money now supposed to be for programs.
Yeah, coming from the social, public health, and population sector, I will always say that the budget for the social sector, for health, for these endeavors are always inadequate. And government and Congress is always choosing between to fund this program versus that. But I still believe that the health sector, the social sector is very much underfunded. And it's a decision that Congress and the executive makes in their negotiation for the budget. If they say that yung contingency fund will go to health, but so much will go to tourism, to economic endeavors, to ayuda, that is something that is a political decision. But if you were to base it on the needs of the people, I would always hope that there needs to be some reversal.
Okay, thank you.
If you really base it on what you see on the ground on these statistics.
Yeah. Thank you, Doc GP. There's another question here from Mr. Enriquez, Carmelo Enriquez. I think the population pyramid change will be the same for all countries. So will this be an advantage or disadvantage to the Philippines? Or how can we convert this into an advantage as a country with large population? I think this is addressed to Dr. Cruz.
Yeah.
Yes.
Thanks, Elma. Yeah. Sana nga. I think all these years, what have we been trying to do? We're trying to slow down the rates of our fertility and mortality. Of course, it has to remain low, or if not even lower, so that we were aiming to reduce the growth rate of the population in order to improve development, because we see clearly the link between population and development. So as I've said, it's like you know, a reboot on our demographic trend. Suddenly, there's this COVID-19 pandemic that really gave us this opportunity to, you know, start off again with a very low natural increase. So will this be an advantage? I think in my presentation, I tried to anticipate what would this mean in terms of future scenarios, in terms of lesser, you know, demand for health, child and infant care, and education needs in the next 5 years, etc., etc. But again, looking at the results presented by Nico, we also have to look at other things. Like I'm a bit concerned with the finding that some of those born this year are affected with malnutrition, no? So ano yung quality ng ating mga young children who will be entering the school in the next in the coming years if they are, they have poor nutritional status. No? So, ang daming dapat pagdugtungin na kwento. But I think if we just look at the counts, and I think this is going to have, as I've said, some favorable impact in terms of, the carrying capacity of our resources, given the very limited resources of our government, the budgets for education, for health, etc. So this will be something positive in a sense for me, and we need to plan well so that the budgets that we have for all this health and education sector should be properly distributed to reap the benefits of this demographic opportunity.
Okay, so thank you very much. We still have 4 minutes, so I would maybe to close this webinar, can I ask each one of you your maybe message or call to what kind of programs, population-related programs, for example, that should be an election issue that should be addressed by the incoming administration? Miko? Or we can start with Doc Francis muna, the historian.
Go
Hindi na nga
back
ako
100 years.
kumikito eh. Yeah. No, historically, as I was always, as I have always been saying, we have seen the neglect in the health sector, both in the colonial and in the post-colonial sector. Having an impact on the state of population, the state of wellness of the majority of the population. And these had some ramifications on the quality of life that we had in the past several years. So it's really incumbent for the next administration to really focus on health, in particular, but social services in general, rather than other perhaps non-social specific programs that may benefit only at the very few and not the majority.
Thank you. Miko?
Yes, thank you, Ma'am Elma. So yeah, I hope that the presentation showed the situation of deaths and births of our country during this pandemic, and I hope it will also help the government to support our hospitals, healthcare, and mental health, of course, as a large share of excess deaths, as we have seen a while ago, are not just COVID-19 deaths, but also related to other causes. So I think the health care part of our country really needs great support, especially this pandemic.
Yes, thank you, Ma'am Grace.
I just want to say that these are exciting times for demographers in particular, and of course historians din. Kasi there are new trends coming, and we need to study further. What are the expected or projected patterns emanating from these changes that we saw in the past 2 years. So we really need, again, I emphasize the need for more data so that we can see, what would be the effect or implications of this. So I would like to ask, the next government to, challenge them maybe to see what would be the response given this demographic, opportunity they can take advantage of to bring our development forward. Thank you.
Okay, Doc GP.
Yes, what I'd like to note at this point is that all of this happened in the last 2 years, and it impacted on Filipino families mainly. And if you look at Filipino families, because of COVID, as of 2021, PSA noted an increase in poverty from 4 million families poor in 2018 to 4.6 million poor in many of the regions that were affected by COVID. So COVID caused higher poverty. And these statistics indicate that the suffering goes beyond poverty, illness, not only from COVID, but other diseases, the weakness of the health system. All of those have to be given importance moving forward. But there is a shining light also. In Muslim Mindanao, they were the least affected. BARM was least affected by COVID with only, I think, a few hundred deaths from COVID. And in BARM, we saw the highest number of people lifted from poverty. 100,000 families were lifted from poverty in Lanao del Sur in 3 years' time. Lanao del Sur was the poorest province in 2018. In 2021, it became the 9th province in terms of the 10 provinces with that jumped from poorest to least poor. It is now the 9th least poor province in the Philippines. So that is something we should study. How could this happen in the middle of a pandemic? If the poverty was not reduced in Lanao del Sur, we would have seen 4.7, 4.8 million families poorer because of COVID. So I would ask social scientists, others, to look into what's happening in the areas that were not affected by COVID, because they're showing a different development trajectory. And maybe that's something for us to learn from. Thank you very much, Professor Elma.
Thank you very much. Thanks a lot to our panelists, Professor Francis Gialogo, Dr. Grace Cruz, Professor Michael Dominic Del Mundo, and Yusik Juan Perez. Thank you for your time. And to all those who attended, we have about 300 attendees, I think, and to the organizers, thanks for doing this webinar, for organizing this webinar. When we thought about this, we noted the need to highlight, 2 years into the pandemic, it's time to look at the changing demographic trends. And what we saw today, it's just 2 of the 3. Hindi pa natin natitignan talaga yung epekto ng migration. So marami pa tayong dapat aralin at pero ang core ata sa discussion natin today is really the need for data. So yung government data, and also for researchers, social scientists and policymakers also to work together to analyze this data correctly and make sense of what we're seeing as trends and patterns, and then from there we base our policy decisions. So maraming salamat po sa inyong partisipasyon ngayong araw, and magkita-kita tayo sa next PCPD webinar.
Initially known as the Population Center Foundation, the Philippine Center for Population and Development was created in 1973 to complement the government's National Population Program. In its first 26 years, PCF implemented projects that delivered information, training, and family planning services. In 1992, the foundation broadened its mandate from population to Population and Development, or PopDev, and it changed its name to the Philippine Center for Population and Development. As a PopDev organization, PCPD implemented projects on community-based health education and services, responsible parenthood, and adolescent development. In 2000, PCPD was reorganized as a grant-giving foundation. It supported the efforts of partners that responded to various concerns, such as housing, waste management, food security, climate change, and reproductive health. In 2020, PCPD decided to shift from giving grants to becoming a social enterprise. It is studying the feasibility of setting up a hospital that would specialize on women's and children's health care, while at the same time provide a broad range of health services to the general public. As it continues to evolve, one thing has remained constant for PCPD. Through its various transformations, PCPD's commitment is to contribute to improve the quality of life of Filipinos.